So let's try to start on time. End of the day, maybe people have plans wherever you want to go visit Bogotá today. So we have a wonderful session this afternoon at the end of the day. That's why it is end of the day, because it's interesting. So, and so the session is on innovative care integration, which is transforming health system for people who use drugs. And we have lined up 4 excellent presenters to discuss different experiences from different parts of the world. So first of all, my name is Zahedul. I'm the Director of Treatment and Procurement at the Alliance for Public Health in Ukraine. So, so let me introduce my speakers. First speaker, actually. First speaker is, just give me a second. My first speaker is Malika Zafar. She's an executive director of an NGO called Zindagi. She's from Pakistan, leads a team that expanded HIV treatment and prevention to 62 districts in Pakistan, launched services in prisons, implemented point-of-care viral load testing, initiated hepatitis C testing and treatment, and established mobile ARV delivery, enhancing care for people who inject drugs and their partners. So, Malika, please. Maybe you could present here, or
okay, this is fine. Thank you for the introduction, and hello everyone. I'm Malika Zafar, Executive Director, Zindagi. So I'll start with a little bit of introduction of my organization and the work that we do, and then move on to our hepatitis C integration into our harm reduction services. So Zindagi was started in 1989 by a group of people who were personally affected by drug use. Our aim is to provide rights-based services to people who use drugs, their families, spouses, and children. So our services, our first point of contact with our clients is via our NSP program. We have outreach workers who go to 500 hotspots, which is where people who, the spots are where people are injecting and where they're dealers to ease sort of the access to services. So we go to 500 hotspots in 62 districts across all 4 provinces of Pakistan, reaching around 38,000 people annually and 5,500 people daily. We provide 3 syringes, 3 needles. Condoms are available on demand, bandages, and spirit swabs. Then we also have antiseptic dressing. We operate in these 62 districts from 45 COPC sites, which is continuum of prevention and care sites. Each site has a paramedic, so we go to the spots and provide antiseptic dressing for those clients who have abscesses from injecting. Then we also have medical linkages to medical care. So we have doctors contracted near the spots where we support our clients to go to the spots to deal with any issue that they may have, and if they need advanced medical care, we also help them and support them to go to the hospitals. Then we have HIV and hepatitis C testing, so it's mobile. We have vans that go to the spots, test all our services are voluntary, rights-based. So we do around 22,000 tests for HIV a year. The prevalence is very high in people who inject drugs. It's around 45% in Pakistan. So that out of 38,000, that leaves around 20,000 people that we test, and we test them routinely. We have follow-ups every 6 months. Then we have ARV adherence support. We have 3 residential facilities where clients can come receive withdrawal management. We have doctors, psychologists, and all our counselors are people who have lived experience of drug use and have HIV. Then we have hepatitis C treatment and support, which I'll speak about a little later. We also have differentiated service ARV delivery. So we have doctors trained who take medicines from the government and go to the spots to give it to the clients. Then we also have point-of-care viral load testing. So we have 4 gene expert machines that go on a route to test clients, and we test around 8,000 people annually. Then we also provide, each of our continuum of prevention care sites also has female outreach workers. So we go to the houses of those clients who are HIV positive and give us permission to access their homes. We test their wives, children, link them to HIV treatment and hepatitis C treatment and PPTCT care. Then we are also in all 23 prisons in Sindh, which is we have 4 provinces in Pakistan. This is one of the provinces, so we cover all the prisons there with HIV testing and treatment, and we are in 2 prisons in another province called KPK. We've been providing these services under the Global Fund grant from 2011. And in our residential facilities, our clients, before they go there, they have to have their baselines before they can get their ARVs, and the ARVs are with the government. So we noticed that the clients who are going to our ART adherence units, around 90% of them who had HIV also were testing positive on the RDTs for hepatitis C. And we tried desperately to link them to treatment. On paper, they're supposed to be excellent government programs, but when you actually try to link clients, either they didn't have medicine, or they didn't have PCR, or they didn't have both. And then they also have this additional requirement of a CNIC, which is a national identity card, to access treatment. And only 15% of our clients have ID cards, because they're people who inject drugs on the street and they don't have cards. Then what we had some savings in our Global Fund grant, so we thought the best use of those implementation savings was to put them in hepatitis C treatment and testing. So we integrated our testing into our harm reduction services, where we were already going, our mobile vans were going to the spots and testing for HIV. So we included hepatitis C tests with that on the rapid test kits. And we sort of managed to secure funding for 3,000 people for hepatitis C treatment, and we also started testing in prisons. We started in 2024, and so far we've tested 26,880 people, and out of that, 10,540 were positive on the RDT kits. So in people who inject drugs, overall, the prevalence is around 50%. And when you look at people who have HIV, the prevalence of hepatitis C is around 90%. So we partnered with Aga Khan, who is they're excellent hospital, one of the best in Pakistan, and they had existing hepatitis C centers in 11 districts. So we linked clients in those districts to the centers, and in surrounding districts, supported them also to go and travel to these centers. So once we tested them and they were positive on the RDT, they went to Aga Khan University, sort of these smaller hospitals and clinics, and there they received diagnostics, consultations, medication, and follow-up. So far we've linked 1,474 clients, out of which 1,064 were positive on the PCRs. Out of the 1,064, 900 started treatment, and of those who were eligible for a post PCR, 76% were negative. So that's quite an achievement for us, especially in this key population. Then we also extended our services to prisons. So in prisons, we don't test only people who inject drugs. We also test people who use drugs. So anyone who uses drugs, test them, obviously voluntarily. So out of the 5,241 inmates tested, 533 were HCV positive. And out of those, 40 also had HIV and hepatitis C. So in prisons, we're linking them. The prison systems in Sindh, 2 of them have hepatitis C treatment options. So we're linking those who are diagnosed to the prison system for treatment. So what's working for us is, most importantly, our relationship with our clients. Over time, we've built a level of trust, and without that, it's impossible to give any services. So that, I feel, is the most important thing in making any program successful. Then also linking with the right, collaborating with the right partners who also have the respect, who also provide our clients with similar treatment, where they're not discriminated against. Because when we take them to the government-run programs for antiretrovirals, because they're the only ones who are allowed to provide them, our clients face immense stigma and discrimination, and it becomes very difficult to take them back. But here, because there was Aga Khan, it made it very easy to seamlessly link our clients and for them to, go back for treatment. So this model, given, additional funding, can be sort of, because there are around 20,000 people who we know are positive with hepatitis C in our services. So 3,000 people we do have treatment for, but this model could easily be expanded with additional funding and replicated in other harm reduction programs. And thank you for your time.
Thank you, Malika. So thank you for the experience from Pakistan. Yes, so now the next presenter is Patrick Smith. Patrick Smith is the manager of Indigenous Wellness of Dr. Peters Center in Canada. Patrick.
Good afternoon, everybody. My name is Patrick Smith. My traditional name is Forebears. I come from the Quagulous Qualcomm people, but I have blood relatives from Chile to Alaska. So I just want to start with a Mother Earth song. Way ya ya, oh, way ya ya, hey ya ya, way ya ya, oh, way ya ya, hey ya ya, way ya ya, way lo, hey ya ya. Makose tome ya dako waka wane kelo, chanu pakele chela. Wakayelo, Jekiayo, Kola Jekiayo, Unchimaka Wakayukelo, Hocho Gakele, Wakayelo, Jekiayo. Kola Jekiayo, way ya ya, 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 way la, Makose tome adako waka wane kelo. Chanu pakele chela, wakayelo, jekiayo, kola jekiayo, uchimaka wakayukelo, hocho gakele, wakayelo, jekiayo. Kola Jekiayo. Thank you. The reason I wanted to start with a Mother Earth song on this day is because that's one of our main mottos, is that food is harm reduction. We could provide all the services in the world, and if we don't feed people, they wouldn't show up. For myself personally, I worked in the downtown east side for about 23 years. Liz Evans was one of my big mentors. She taught me about radical kindness, how to treat people with dignity, and how to, also people, have the dignity of death. They always had a minister on staff, all the time. And that became a big part of my work, was, burying people, singing them home, things like that. I'm going to have to stand over here because I can't read.
Oh, okay.
So, yeah. Now I work at the Dr. Peters Center. You know, I've really found a home there. It's a place of healing, a place of wellness, a place that is saturated with programs. You know, we have everything from pet therapy to art therapy. You know, we have, you know, you can read for the slide there that we have, you know, 38 complex care residents, you know, really people who are really, really, you know, sick. But their spirit and their willingness to participate in life is, you know, outstanding. You know, we have an OAT program where we're one of the first in Canada. We're the first in Canada, you know. And then we also have, so in the last 3 years or 2 years, we went from 3 Latino participants to 9. I don't know how it happened, but we went to 90 Latino participants in 2 years, you know, and they, you know, they came there and they probably, you know, all come and they have a, you know, an outlook similar to how I feel in Colombia, kind of, except I have lots of resources here. You know, they don't. You know, they come there, but they find a home and a place, you know, in a community, you know, and they also, you know, English is a barrier. They have unstable housing. Poverty creates pathways to undesirable action, but most of them are really, you know, they do well there. You know, they really find a way of healing, you know. But they always come, you know, and they're really appreciate it when we heal through culture. Because, you know, myself personally, I believe we're living in times of prophecy. You know, shortly after working at the Dr. Peters Center, you know, somebody gave me a condor feather. You know, and condor feathers are quite rare in Canada. You know, and there's a 500-year-old prophecy that talks about the eagle and the condor. You know, and the eagle represents the masculine, the technological, you know, all the dominant forces in the world, where, you know, the condor represents the feminine, the intuition, the connection to Mother Earth, you know, things like that, you know. So, you know, we work with all people through, you know, we write this into we just recently started working this into our care plans, you know, for all people that come to our center. They, you know, they all have you know, this written into their care plan, you know, emotional, spiritual, physical, mental goals of, you know, getting well, you know. And then this medicine wheel goes back a long ways. A lot of people know it. There's different ones, and you can go on ad infinitum about the medicine wheel and the way it's used to help heal generations, you know. So yeah, like I was saying, food is harm reduction, you know. The meals that they have there are outstanding meals. I've yet to finish one, you know. You know, people come there, the chefs have 5 Red Seal chefs. They know your name. They come in and, you know, if you don't like fish, you get an alternate. You know, if it's your birthday, you get to pick the meal that day. Well, you can't tell them on the same day, but you know, you have to tell them, you know, a week ahead or so, and they'll make whatever you ask. If you ask for steak and lobster, that's what you get, you know. You know, we don't have any hidden agendas, you know, that for the mental part. You don't have to take your meds. You can show up just for a meal and leave and not say nothing. You know, you can do whatever you want. You know, you have a choice to be who you are as a human being. You know, and that's always served me well, when you have choice. You know, that's a totem pole that we have right in the middle of it. As soon as you walk in the front door, we have a big totem pole that we just dedicated to Dr. Peters' mom, which is a very interesting story in itself. You know, but, you know, and like I was saying, we have so many services. Like, I've worked in lots of nonprofits down in the downtown east side, whereas everything from the janitor to the, you know, yeah, front desk guy to, yeah, you're everything. And it was, but here we have, you know, so many different services that, you know, you can come as you are. And this guy, he comes up once a year from Mexico, Don Chabello. You know, me, I'm just an ordinary human being. You know, I take people and try and create programs as best I can for them. You know, but he's a true healer. You know, he spends 25 years studying one medicine. You know, he has to spend 5 years fasting in each direction and 5 years in the middle before he can, you know, studying one medicine. before he can see anybody. And then after that, he starts to see people. But he comes once a year, and the Latino people really appreciate it when he comes. So our goal is to create a safe, welcoming place for people to belong. Our core beliefs that, humanity heals. I've heard that time and time again, that humanity heals. We just have to learn to be human and kind to each other. It's not rocket science, or rocket surgery or whatever you want to say, But, I'd really like to thank you for your time and ability to share. And I brought with me, I'll give it to one of the elders here because, an eagle feather that I'm going to share, just to, complete that part of that prophecy, that little bit. If we all do a little bit and get that same canoe together and all row together in one direction, maybe we'll get somewhere. Because right now, for our children and our children's children's sake, we owe it to them, to create a better world, a better future, a better life, I'll talk to you, Wesson.
Awesome. Thank you. Thank you so much for, bringing us all to the nature. And I think that's a powerful kind of ending there with the humanity heals. So currently what is happening in the world, I think we need that kind of messages. So thank you, Peter, for that message. So in terms of your ceremony, maybe whenever you like to do it later, yeah? Thanks. So now maybe shall we, I'm sure there are some questions maybe you have. So please do post your questions online if you want. But also since we are a small group, we can have maybe, questions at the end of the session so we could, everyone can speak and we will take questions at the end of all our speakers spoken. So our next presenter is Nalinikanta Rajkumar. Nalinikanta comes from Manipur, India. He's the president of the Community Network for Empowerment in Manipur. That's an organization. A former drug user, living with HIV for 20 years. He has worked in HIV and viral hepatitis since 2003. He leads impactful programs, including same-day hepatitis C testing and treatment in correctional facilities. So I give Nalini.
Our respected chair, our respected panel members, and my dear brother and sister, thank you for the opportunity to be here and to share the key finding of the hepatitis B vaccination study during this Harm Reduction International Conference. I am truly grateful to be one of the members in this panel, and I also kindly ask for your patience and understanding regarding my stammering. So, okay, let me begin by giving you a brief background about our organization. CON stands for Community Network for Empowerment, which is a drug user-led network of 7 community-based organizations of people who use drugs based in Manipur, India, and it was established in 2011. Since its inception, we have been working on range of activity, including enhancing access to screening, vaccination, diagnosis, and treatment of viral hepatitis B and C. We also do quite a numbers of hepatitis C related activity, including same-day test and treat, which I believe is the first community-led initiative offering same-day test and treat for hepatitis C. We have also shown that hepatitis C screening, diagnosis, and treatment can be effectively carried out within the prison setting without the need to transfer the inmate outside. This approach was highlighted in the WHO policy brief in 2018. In addition, we also work to improve HIV diagnosis, care and treatment for people who inject drug. The organization also addressed human rights violation issue at drug treatment center, and also we work on raising legal awareness among people who among people living with HIV, empowering them to understand and assert their legal right and access necessary legal services. To give you further a little bit background on the genesis of the study, in 2012, WHO have recommended rapid regimen for hepatitis B, specifically for people who inject drug. This was a conditional recommendation based on limited evidence quality, despite an understanding of the benefit. WHO and other global health organizations like Global Fund and US CDC also strongly support for vaccination of hepatitis B among high-risk group. However, there has not been enough data on the effectiveness of the rapid regimen schedule. A study on its efficacy has not been done in the past 30 years, which is why rapid regimen has not been widely adopted. So as a result, the national program in India also followed the standard schedule of 6 months. So therefore, to understand the efficacy of the rapid regimen schedule among people who inject drug, we took forward a study in partnership with different organizations, as a compliance rate for the 6-month schedule is very challenging among people who inject drug. Going on to how we have done this in terms of the method that were involved, a total of 677 people who inject drug and people living with HIV received 3-dose hepatitis vaccine using a rapid regimen schedule of 07-21 days between October 2017 and August 2022. The vaccine was administered by the trained peer members from our organization to ensure community-led implementations. So of those total vaccinated, 372 participants were later identified for anti-HBs tests to assess their immune response. The blood sample were collected from the participant after an interval of 1 to 5 years from the initial dose to conduct anti-HBs tests. The blood sample were first stored at a local diagnostic laboratory and sent in a basis on a monthly basis to the central laboratory for anti-HBs testing. So based on the methodology described here are the main results, outcome of the study. Out of the 677 PIVT and PLHIV who received rapid hepatitis B vaccination schedule, all of them have successfully completed all 3 doses, achieving 100% compliance rate. And then out of 372 follow-up tests to check if they develop protection by this follow-up test was done to check if they develop protection by measuring their anti-HBs antibody level. So of those, among those tested, 85% had titer above 10, indicating protections. However, 56 participants had antibody below the threshold, showing insufficient immune protections and the need for a booster dose. We also evaluate how participant was responded from the booster dose. This slide presents the data of the non-responder who received a booster dose. Among the 56 participants with anti-HBs titer less than 10, even after completion of the initial 3-dose rapid vaccination schedule, 50 of them have consented to receive 1 ml standard dose of vaccine. Anti-HBs level were retested following the booster dose to evaluate their immune response. Surprisingly, 46 86% had achieved seroprotections. However, 7 participants did not respond to the booster dose, showing that this subgroup may need a difficult vaccine plan. Later on, to evaluate the efficacy of the rapid regimen schedule among people who inject drug against the standard schedule of 0, 1, and 6 months, a comparative analysis was done by our organization. What we observe is in the rapid regimen arm, 92.1% achieved seroprotections, indicating a strong immune response, and within a shorter time frame. In comparison, standard regimen arm shows slightly higher efficacy with 99.5% of the participants achieved seroprotection. So this finding shows that though standard schedule is a bit more effective, but rapid schedule is still a good options for high risk or the mobile populations where adherence to 6 months vaccination schedule may be challenging. So I may not be able to explain in detail the technical difference between the seroconversion and seroprotection because this aspect was handled by the head of the Department of Hepatology, Sanjay Gandhi Postgraduate Institute of Medical Science, and other subject expert. As a community representative, our role was taking active part in the field work during the research and maintaining the data. If anyone among you is interested, the details of the study can be found from the Journal of Clinical and Experimental Hepatology, where it was published earlier this year. So in conclusion, the 21 days rapid hepatitis B vaccinations has proven to be feasible and more effective among people who inject drug and people living with HIV. The program, the compliance rate for the rapid vaccination schedule of 0, 7, and 21 days was 100. Notably, 85% among those tested had a developed protection level without the need of a booster dose. Among those who did not respond this one earlier, we found 86% of them rising their titer above 10 after receiving the booster dose. The rapid regimen schedule gave similar protection with as the 6 months standard schedule, making it practical and effective option for public health. This approach is helpful for the high-risk population and can help reduce hepatitis B new infection. Reducing hepatitis B new infection is reducing harm that can cause liver cancer among people who inject drug. So this is my last slide. I would like to thank all the members from our organization who take active part in conducting this study, and also I would like to thank all the community members who volunteered themselves to be a part of this study. I would also like to thank Street Asia, MFAR Bangkok, AGPGI Lucknow, India, Babina Diagnostics for their technical guidance, and lastly, South and Southeast Asia SASI platform for their financial assistance to conduct this study. Thank you so much.
Thank you, Rajkumar, for giving us, I mean, it's an experience that how community can engage into developing researches and also doing the researches together with the scientific communities. And so I think Manipur is not really a easy context because there is, war going on among the population. So I think having that kind of collaboration with the research institutes and the NGOs, I think that is really, really a good example. Thank you for that. So our next presenter is Anna Meteliuk. Anna Meteliuk has an education from MS in epidemiology from State University of New York. She has been working in HIV prevention among people who inject drugs in Ukraine since 2007. She currently works with the Alliance for Public Health in Ukraine and work in a project which is HIV prevention treatment among people injecting drugs. So, Anya.
Thank you, Zahedul. Can I have a clicker? Thank you. So my name is Anna Meteliuk. I represent Alliance for Public Health Ukraine, and I would like to present you, to introduce you to the new study that we have been working on for the past 2 years, and we are currently launching, about to start the implementation phase. So I would like to explain to you what has been done and what we are suggesting for people who inject drugs. So the intervention I will be talking about is the community-initiated HCV testing and treatment. It's a four-year project funded by Unitate, and the goal of it is to contribute the evidence to the global efforts in combating HCV among people who inject drugs by identifying effective strategies to overcome barriers to testing and treatment, and ultimately advancing the goals of the WHO's global hepatitis strategy to eliminate HCV as a public health threat. So we, within this initiative, we are working in 3 countries, which are Egypt, Kyrgyzstan, and Nigeria. The reason for choosing those countries is that because of the high prevalence of HCV in people who inject drugs in these countries. So according to the last estimates, the prevalence of HCV in people who inject drugs in Egypt, Kyrgyzstan, and Nigeria is at least 10% and reaches from 50 to 60% in certain areas of the countries. So the people who will have access to our intervention are people who use drugs in the past 90 days. They have to be 18 years and older, and they have to be tested positive for HCV RNA, meaning having confirmed HCV infection. So the intervention itself is that we will test what we call a community-based simplified HCV testing and treatment algorithm implemented at the community harm reduction organizations. And I will give you more details later on. So as for the study overview, this is a prospective observational non-randomized cohort study, and it will assess the feasibility and the effectiveness of the community-based initiated HCV treatment among people who inject drugs. The aim of our study is to assess the effectiveness of integrating the service of HCV testing and treatment into community-based organization, meaning we will be avoiding the health persons who inject drugs contact with healthcare facility and try to provide as many services to him as possible at community-based organization. And within this intervention, we will determine the factors and service provision modalities associated with better outcomes of HCV testing and treatment among people who inject drugs in community. So implementation of this research is aimed primarily at exploratory assessment of the integration of HCV testing and treatment program into existing community-based harm reduction services. This model includes the community-based point-of-care RNA testing conducted by lab technicians and the simplified medical staff-led clinical pathway, meaning we are procuring gene experts. This is the machine that allows confirmed HCV infection, and the machine is placed at community-based level, meaning everything from testing to confirmation to provision of treatment to to reinfection for HCV at 12 months will be happening at community. So as I already mentioned, we are working in Egypt, Kyrgyzstan, and Nigeria. So we are partnering with one NGOs in each of those countries. So our study has the goal of assess the feasibility and effectiveness of integrating HCV testing and treatment within community-based harm reduction programs for people who inject drugs and identify key factors and implementation options that are associated with those outcomes. And our study has 5 objectives. The first objective is to identify feasible implementation options for the key elements of the community-based simplified HCV testing and treatment algorithm and define the optimal model of introduction such algorithm into the community. We will also evaluate the effectiveness of the simplified algorithm that we are suggesting. Here our observational cohort study comes in place. Our next objective is to identify factors associated with HCV testing and treatment outcomes. We will collect quantitative data at several data points for each of the participants to see the progress, to see the dynamics, and to see what went good and what went not good. We will also assess rates of reinfection and factors associated with reinfection. So we will have follow-up testing of reinfection at 6 and 12 months upon completion of upon SVR, and this will also take place at the community level. And we will also evaluate acceptability, barriers, and facilitators for the implementation of the community-based HCV testing and treatment. Our study also implies the qualitative component, meaning in-depth interviews and focus group discussions among both people who inject drugs, our patients themselves, and the providers. So I have been talking a lot about simplified community-based HCV testing and treatment algorithm. So the features of it. It's a community-based service provision, lowering the threshold for the HCV services and eliminating the need to visit healthcare facilities for the majority of our patients. We will use simple, once-daily, pan-genotypic HCV treatment regimens. Those are DAAs for the 12 weeks of treatment. Our simplified mechanism requires a minimum of lab tests and assessments. It also implies task sharing of essential functions from physicians to case managers and integration of HCV testing and treatment with existing harm reduction services, addressing multiple needs and facilitating patient-centered care. So the intervention pathway, what we are actually suggesting to our participants. So the community-based organization will test people who inject drugs in hotspots and drop-in centers using HCV rapid tests and identify positive cases. Among those positive cases, so people who inject drugs will be invited from hotspots, drop-in centers, or they can be tested at that community-based organization. They will be confirmed using HCV RNA with GeneXpert and confirm positive cases at the community-based organization. For those confirmed positive cases, other blood tests will be taken, also the blood work will be taken from community-based organization, and the blood work will be done either also at community-based organization, like in Egypt, for example, they have a fully equipped lab at a harm reduction setting, or transported to the nearby private lab in Kyrgyzstan, or the governmental healthcare facility. This is the model we have in Nigeria. The reason for having those additional blood tests is that because we call it a simplified cohort, this is a simplified algorithm, right? So we can only take, let's say, easy HCV positive cases. So we are not taking people who will be screened for positive for TB. We will not be taking people who will be screened positive for Hep B. We will not take HIV positive people, and we will not be recruiting women who are pregnant or breastfeeding. So that's the reason we are having additional blood tests. So after we identify people eligible for our simplified cohort, the physician from the local special facility will select potential patients eligible for our simplified cohort based on the lab results, meaning we are recruiting the infectious disease doctor who will be coming to community-based organization to evaluate the person and prescribe DAAs. So the engaged physician at community-based organization will prescribe HCV medications and provide 28-day supply of medication to patients at community-based organization. The stock of medications will also be kept at community-based organization. And medical data, clinical data for all patients that will be prescribed HCV treatment within the study will be also available to governmental partners to feed the national HCV registers. So when I talk about GeneXpert, you see this picture in the middle. So it's like a small machine, like a printer, like office printer machines that can be easily placed on the table. So it doesn't take a lot of space. And to the left and to the right, the pictures, you can see this is actually the community-based organization in Bishkek, the capital of Kyrgyzstan. So on the left is actually the lab where the machine is going to be placed. And on the picture on the right is doctor's office where the physician will be evaluating the patients. So as for the study design, as I said, it's the prospective observational non-randomized cohort study, meaning that we will be recruiting patients, collect data from baseline and follow them up for the whole treatment course, as well as SVR, as well as 12 months after SVR for reinfection. So each patient will be From each patient, the data will be collected at several data points. We will use the mixed methods approach for data collection. And as for the sample size, for all 3 countries, we are planning to screen almost 14,000 people, and 14,000 people, and we expect that about 10% of those will actually get their SVR at 12 months. So as for participants' inclusion criteria, those will be people who inject drugs. They have to be 18 years and older. They have to be HCV RNA confirmed, regardless of the previous treatment experience. As I said, we are excluding those TB, HBV, pregnancy, and breastfeeding. They will have to be available to follow up. This can be possession of the cell phone or some social networks or whatever, so that we could trace the patient, and willingness and ability to provide informed consent. So as for the participants' recruitment steps, the outreach workers or peers will introduce rapid HCV testing and inform the possibility of HCV treatment. The recruitment of the treatment cohort starts at a community-based setting or outreach points for people who inject drugs. And screening, required lab work, and initiation of HCV treatment will take place at a community-based setting. So our study has several primary and secondary outcomes. Our primary outcomes are, well, basically completion of HCV treatment cascade. Also the number of people screened, the number of people diagnosed with HCV, the number of people who will actually initiate treatment, the number of people who will complete treatment, number of people who receive SVR, and number of people with reinfection rates at 6 and 12 months. And as for the secondary outcomes, this will be treatment motivation, treatment adherence, treatment satisfaction, quality of life, additional drug use, blood-borne infection risk, and mental health. So this is a heavy slide, but as I mentioned, we will be using the mixed methods approach, meaning we will have qualitative and quantitative components. In terms of quantitative component, all those people who inject drugs who will be eligible for our simplified cohort will fill in the structured computer-based survey using standardized tools. That will be social demographics, depression, substance use, alcohol use disorders, trust in physician scale, blood-borne infection risk behavior, family and social support, quality of life, health-seeking behavior, and health service utilization. And each patient will have to fill in the same survey at several data points so that we were able to see the progression, to see what's going on. And in terms of qualitative component, we will have in-depth semi-structured interviews and focus group discussions, also at several data points, at both among providers and patients themselves, to evaluate the values and preferences of the simplified cohort. So as I said, we are already 2 years into the project and we are about to start. Almost all the preparatory work has been done. So we have approved our study protocol by WHO Ethical Review Committee. The local country study protocols have been approved by local ethical review boards. The medication is supplied to most of the countries. The rapid tests for HCV, HBV, pregnancy are procured. Community-based organization, which is very important, obtained lab licenses for project implementation. First patients are expected to start our HCV treatment in June this year. Also a very important milestone is this algorithm that we are suggested at the end of 2024 was added to the Kyrgyz national HCV treatment guidelines, meaning they are already approved at national level. And I thank you for your attention.
Thank you very much. Thank you very much, Anya. So it was very, good in terms of presentation in a way that also the research which is presented, because it's a multi-country research and very complex. Community-based hepatitis C treatment program has been happening also in Ukraine, but this is a new way of doing it. So I think I find the presentation and also the model of treatment in terms of community-based, completely done in community. In other models, what we had is like we are sharing the responsibilities between the healthcare facilities and the community. So here, complete community-based, I think it would be quite interesting study. Also looking at multiple countries to see how different countries' community setting respond to the treatment modalities. So that's also very interesting. I find the presentation and the study design. So I thank all the presenters. So now we actually open for questions. And so I already see some hands. Please introduce yourself very briefly and put your question. Thank you.
Great. Hi, my name is Kimberly. I am from Seattle, Washington in USA. I work at a hepatitis organization where we actually host a very similar simplified treatment model. Community-based providers come to our site. We're also a syringe service exchange, so it's very embedded in harm reduction services as well. My question is maybe for all of you, but I noticed in the first presentation that I don't remember the specific figures, but the percentages were very high for people moving along the continuum of care. So folks that you tested and then linked to, they actually like made their follow-up appointment for the RNA and then they were linked to care and started treatment. And even for the Hep B vaccine schedule, I think you had like 100% of people followed that vaccine schedule. One thing that we see a lot in our program, we have care coordinators who work very closely with folks who are seeking treatment. And even still with that intensive care coordination component, we lose contact with so many people along the process for a lot of different reasons. We're mostly working with folks who live outside, and because of police clearing places where people live, it's very hard to keep track of people. There's a lot of reasons. But I guess what my question is, for anyone who would like to answer, is if you could talk any more about the specifics about how you are able to follow along with clients who might be experiencing different levels of instability in their lives, like what strategies you have for keeping them engaged throughout the process and keeping in contact with them.
Yeah. So since we only had funding for 3,000 people, our first cohort was those people who are already adherent on ARVs. So that's one of the reasons why our linkage. Otherwise, in our needle syringe program, we have the same issue. People come in, people go out. So every 6 months, we see, a number that goes, a number that comes, because again, it's a mobile population. In Pakistan, you have involuntary rehabilitation centers, so families put them in centers, then there are police raids, and because our clients are the easiest targets, they'll be, so that is an issue that we face also. I think one thing that helps is that we were giving living support packages to those, the families of those people who were HIV positive. So every quarter we were engaging their families, and when you engage the families, the adherence is higher. Now, unfortunately, because of budget cuts, after 12 years of giving this consistently, we've stopped. So we'll see what changes that leads to. But because Pakistan is a very nuclear family system, so I think that is one thing that helps. And then we have very regular contact with our clients. So our outreach workers go 6 days a week to the spots to give them syringes. So that's the contact frequency also helps us sort of keep. And then we also have social mobilizers who support them to go to the centers. So we're covering the transport, we're covering all costs related to travel, medication, etc.
Rajkumar, you want to respond?
See, what inspired us to took forward this hepatitis B vaccine studies is actually before the national program rollout in India, we already launched a hepatitis B vaccination campaign following the rapid regimen schedule of 0, 7, and 21 days, where we found the compliance to all the 3 doses to be 100%. After the introductions of the national program in India, due to the lack of data on the effectiveness of rapid regimen schedule, national program follows 6-month standard schedule. So in one of our projects supported by Gilead Science, we screened more than 3,000 people who inject drug for hepatitis B. The positivity rate comparing with hepatitis C was very low, but in case of hepatitis B, the percentage of the people who inject drug susceptible to hepatitis B was very high. Though the schedule that we follow was 6 months. So one of the outcome from that project was the compliance to second dose was 80, and the compliance rate to third dose was 48%. So this was a retrospective study where we, reach out to those whom we have already vaccinated. So when we compare the compliance rate, especially for the high risk or the hard to risk population like PUID, we are just generating this data to start advocating our government to at least consider rapid regimen schedule for drug user. For the general population, we have no opinion.
Thank you.
One more thing.
Yeah.
So another reason that the adherence is higher is because of the quality of the healthcare service provider that we're linking them to. When we link them to antiretrovirals, which is provided by the government, we see a massive dropout rate because of the way that they're treated, the sort of timings of the center. So that's another reason, is how well they're treated by the service provider you link them to.
Thank you. All right, so please.
Hi. I've been really lucky to have been to your project many years ago when Tarek was involved. It was running the project, I think. And one of the things that seemed to me when I was really impressed with the project, but I don't know, I was trying to look at through your website, was the issue about social enterprise as well, where you're engaging the service users. You couldn't always give them medication because of laws and things like that. But are you still involved in that part of work, still trying to give opportunities to people who use drugs? And that can apply elsewhere. And the other part was that you were very much involved with the network of agencies in Southeast Asia. You mentioned it. I was wondering how that's working, because that, to me, seemed... I know that you had really good relationships in those days with Sahara and Sharon and different projects. I was just wondering if that's continuing as well.
So no, it's not continuing so much. I mean, I think the strong networks are... Pakistan doesn't have a network. We've been trying to create one or support somebody, but we're unable to get support. So currently there is a network that says it does work, but it's not a network, it's a political issue. So that is one thing that is massively lacking, is the voice of people who use drugs coming to informing decision making. Right now, we're sort of the lone voice for our clients. And your second thing of providing opportunity, so those programs were funded by Mainline, mainly where we were able to support people in learning how to grow vegetables and carpentry. But once the mainline support was not there, they were unable to be sustainable. But what we do is that in our 3 residential facilities, all our counselors are people who have been through our program. So they are people who have lived experience of drug use and are HIV positive. So we rehire them and train them as counselors. And then we have priority hiring for outreach workers, social mobilizers, for people who inject drugs. So they're given priority. So that's how we reintegrate them, but we don't have specific projects, unfortunately. And that's a huge missing link also in our services. Thank you.
Thank you. Maybe Rajkumar wants to respond a little bit now.
See, the advantage of having a proper system of networking, as per my experiences, see, gone before the national program rollout in India, we have already started organizing mobile outreach camp. So the advantage is, since earlier we have the affiliated number of community-based organization in our network was 11, but now due to the ongoing crisis in Manipur, now it has been reduced to 7 community-based organizations. The advantage is they are the one who help us to mobilize to, organize the mobile hepatitis C screening camp. So they will take the network member will take the responsibility of mobilizing our community. We will go down, organize the on-site rapid diagnostic test. Whoever tested antibody positive, their blood sample will be collected and transported to the national program for further RNA testing. So yes, there is a need to have a proper networking system if we want to expand the distinct testing and treatment coverage.
Thank you. Yes, Carrie? No, take the mic.
Excellent presentations, really enjoyed them all and really appreciate all of your work. Just for the presenter from Ukraine, from the Unitate program, can you tell us a little bit more about the organizations that you chose to do this pilot? Were they hepatitis organizations or primarily HIV organizations or harm reduction? Because obviously in those 3 settings, like the definition of an NGO is quite different, so it'd be really interesting to hear that. And for the presenter from Pakistan, I think it's really great that you've been accessing global funds to do some of this Hep C work. And I think you said the first time you did it was from a reallocation of underspend, is that right? And then in the latest round of funding, you could actually put in more hepatitis C related services at the beginning. Did you do that? And I guess the follow-on question, with what we know about Global Fund asking people to make 30% cuts in their programs, do you think that your Hep C services will survive that? Thanks.
A lot of questions. Yes, Anya, go ahead.
Okay, so all the 3 organizations that we chose are existing harm reduction community-based organizations who already are providing harm reduction services to people who inject drugs in those countries. And those are the largest NGOs providing HIV and HCV testing services. That's why we approach to them, so that they already have the mechanism of reaching out to them, providing harm reduction services already, outreach work and counseling, and we are just adding a new kind of intervention, a new service into the existing harm reduction program within those community-based organizations.
Thank you.
Yes, so we did put it into our current Global Fund grant, which is till 2026. And we saved from our previous year. And now it depends on the wisdom of the country team whether they will let us use it for hepatitis C treatment or reallocate it. So we have it right now in our bank, but we're waiting for their go-ahead. Yeah.
Great, thanks. Any other questions? Oh, there you go.
This question is for Anna. So I'm from Hepatitis Education Project as well in Seattle, same organization. So I was wondering whether, so I guess for a little background, our organization currently works with a pharmacy-based model where we're able to go straight from Hep C antibody testing to staging labs. So we'll just skip drawing the PCR and draw all the labs right away. What benefit do you see in using GeneXpert and then staging versus just using Hep C antibody and then drawing labs?
Well, first of all, we have to follow country, HCV treatment, testing and treatment guidelines. So we cannot, drop that step. And we see that, and the reason we chose this model, meaning GeneXpert at the community-based setting, is because that's the kind of the path, that's the interval where most of the patients get lost between being HCV positive using rapid test and actually being linked to treatment, because they had to go, they can be tested at outreach points, hotspots, dropping centers, anywhere, but they do not actually go to the lab to get confirmation, and in most of the cases they have to pay for that. That's why we chose that GeneXpert is a good option, also being placed at community-based, to kind of make this path as short as possible.
Thank you. Yeah. I guess, no.
Okay, thank you. There's a question at the back. Oh, you want to go?
Hi everyone, my name is Javiera. I do research, pharmacy, harm reduction, public health related research, so my question is for Anna as well. So it might be a bit structured, so apologies for that because I'm interested in the protocol per se. So my first question is regarding your eligibility criteria, and if I'm not wrong, one of the points you had there was for clients to have some sort of follow-up or contact information. So the first question would be around that, how you see that maybe being a challenge for people to engage with the program or for you to engage with your clients. And maybe it's context dependent, I don't know, so that'll be the first question. And then the second one related to dispensing therapy, as this is a daily therapy for a period of time. What challenges you foresee as well on those regards with people that might not be present at the location every day for the therapy, or maybe you are considering dispensing more than daily medication for maybe someone that you know might benefit from having more than one day therapy on their hands.
Okay, thank you for your questions. So to answer your first question, the reason we need to be able to follow up those patients is because we will be dispensing on a visit, like on the day one when the person sees the doctor will give right away 28-day stock of medication. So the person will be visiting the doctor just 3 times, within the 3 months period of treatment. That's why we have to be able to follow them up if the person doesn't show up. Which is not the problem in Egypt and Kyrgyzstan, but is a problem in Nigeria because some people who inject drugs do not have cell phones. That's why we have, not we, I mean the community-based organization we are partnering with, have a mechanism of tracing those people through peers, through close environment, parents, partners, friends, anybody. So that's the point, that's the reason why we need, why that's one of the eligibility criteria. And did I answer your question? So, and I think I answered your second question as well.
All right, thank you. Any other questions from? Okay, so I have one question, if to Patrick. So Patrick, I mean, you have described as your approach is more nature to the art. I also noticed that you said trauma-informed approach. Can you kind of elaborate that a little bit for us? I'm not really didn't get it. So if you could, I mean, you can take the mic. Anna, can you press the mic?
I mean, I think everybody in this day and age has some sort of trauma, whether it's mental, physical, emotional, spiritual. People have varying degrees, and what helps them is a unique individualistic approach, but I think choice is key, making people key empowered choices that, what helps them. But there's so many things in this world that can help people. I don't think we have to look outside the box lots of times and to look into the past and see things through the eyes of our ancestors. Hope that answers your question.
Yeah, thank you. No, that's good. Thanks. So I'm just thinking if there's no other question. We have still a few more time, but I think if there is no question, maybe I have a few more questions for the for the presenters, but I mean, it is the end of the day. Maybe we could really close the session, yeah? So I would like to thank all our presenters for wonderful presentations. And also, I think, bringing experience from different perspectives, and also, sharing the knowledge how community can engage with actually academics and making the work together. Because most of the time we say when we look at, research, academics, and we think communities are always saying, okay, community can't do it. No, but there is really examples how we can do it. And also coming with the community-based Hep C programs, I think this is really the way to go, because if we look at number of countries where Hep C, prevalence, I mean, you mentioned among HIV positive in Pakistan, 90%. That is a staggering number, isn't it? And if we look at Ukraine, we have also around, among people injecting drugs, 65, 70%. And so I think there is much more community engagement is needed in terms of addressing hepatitis C treatment program. And of course, without community healing, community engagement, and without connecting with nature, I think we will also not be able to do it. So with that, I would like to thank all our presenters and all our participants for all the questions. So thank you very much for joining. So I wish you a wonderful evening. Thank you.